Research is something which is very close to my heart, so no doubt I'm going to enjoy this session.
So the format would be slightly different, and being online in a platform and trying to get the PGs to talk about a publication. And
to me, I think it's a very nice learning initiative.
Today we are going to discuss very interesting for the first time the Journal Club, and in this I would like to introduce our moderators who are very senior members. Welcome to all of them. Dr. Bala Bhaskar, who we all know as a very senior member and a person who has been interested in research for so long. He is the Professor, Department of Anesthesiology in WIMS, Bellary. He was not only the Chairman Academic Committee, but also the President of the ISA National, which is so important, and also the past Editor-in-Chief in IJA. Welcome, Dr. Bala Bhaskar. Our the second moderator is Dr. Lekshmi Kumar. She is the professor and head the Department of Anesthesia at the Erector Institute of Medical Sciences and Research Center. She is, of course, she has a fellowship in pediatric anesthesia. She also is performing a lot of liver transplants that I know of. She's an associate editor of pediatric anesthesia and editor of several journals. And of course, she has many publications to her credit. Welcome, Dr. Lekshmi. And our third moderator is Dr. Asha Tyagi, a very senior professor. She's the director professor in the Department of Anesthesiology and Critical Care at the UCMS GTB Hospital. She also has more than 100 index publications with a vast area of interest in critical care, obstetric anesthesia, and research methodology. And she's an ardent teacher participating in several seminars and webinars in Delhi. So I would like to welcome all of them to this ICA PG Assembly and the Journal Club. And here, of course, I would request Dr. Sanish to introduce the speakers. Thank you.
Thank you very much, ma'am. It's my pleasure to be part of our ICA PG Assembly, which was designed as the voice of the future. Here we give opportunities for the upcoming anesthesiologists, the voice of the future, the postgraduates in anesthesiology, to come over to the dais and present the topic. Initially, we had pro-con debates, then we had postgraduate seminars, we had a PG conclave where we saw postgraduates across the country coming out with their perspective on how anesthesia education is progressing. Here we are starting a new venture of presenting a journal club, which is actually meant to have a critical appraisal as an academic program for anesthesiology postgraduates. So at the outset, I would like to have a few initial remarks from our moderators. Can I have Dr. Bala Bhaskar for your initial remarks on how we are planning to conduct this?
Yeah, thank you, Dr. Sanish. Good evening to all our senior office bearers of ICA. So as Dr. Sanish has informed, this indeed is a novel session, basically. So we have all been used to having the journal clubs in the physical form within the departments in our different medical colleges. So the format would be slightly different, and being online in a platform and trying to get the PGs to talk about a publication and get them to critically appraise, and simultaneously expecting other people across the world to also listen to the critical appraisal is slightly a different and new experience for me also. So that way, I'm very happy to be part of this session. And in this regard, I also know about the PGs who have also struggled, and they have basically prepared nicely. So all the best for the students also, and wishing for the success of this type of program also in the future. Thank you.
Thank you very much, sir. And shall I request Dr. Lekshmi Kumar for initial remarks?
Yeah, thank you, Dr. Sanish. To me, I think it's a very nice learning initiative, more for the teachers at this point, because many of us publish and there are a lot of lacunae that when we submit the articles, the criticisms are strong. Perhaps this will be a form of exercise when the teacher and thereby the taught can actually improve, and maybe our research will be more channelized. I think I should congratulate you for the courage to take up this venture. And of course, I would be very happy to interact with the other moderators who probably have more research background than I. And let's see how it goes.
Definitely, ma'am. Thank you very much for joining us. Shall I have initial remarks from Dr. Asha Tyagi, please?
Yeah. Good evening, everybody. Firstly, I'd like to thank all my seniors for giving me this opportunity, because research is something which is very close to my heart. So no doubt I'm going to enjoy this session. And because I also feel that research methodology is such a perceived need and yet a lacunae in our curriculum, that probably having journal clubs this way is one of the best ways to teach about research. So for that, I really congratulate ICA to have thought of this. And all my seniors here who I'm sure have advised for this and have come up with this idea. And I just one little remark to our postgrad students, that maybe they will find things which faculty is discussing to be a little over the top and may not understand all of it. But then this is the only way forward, that it is by informal discussions like this that the foundation for understanding research is going to be laid. So thank you, and I'm looking forward to an excellent session.
Thank you very much. Now it's time to go over to the voice of the future. It's my proud pleasure to invite the first team from Dayanand Medical College and Hospital, Ludhiana, Dr. Rushal Nayar and Dr. Sunanda Sethi, with acknowledging the contribution of Dr. Anju Grewal for accepting our invitation to have postgraduates from her institution to participate in ICA PG Assembly. Over to you, Dr. Rushal and Dr. Sunanda Sethi. Kindly introduce yourselves and then start your presentation. As we go along your presentations, the moderators will be interacting with you for clarifications and comments. All the best. It's your time now. Dr. Rushal and Dr. Sunanda, please.
Thank you so much, sir, for the opportunity. Good evening to all respected faculty and our respected teachers and our dear colleagues. I am Dr. Rushal and I am Dr. Sunanda. And today we are going to present the article which was published in the journal Anesthesia in 22. The topic of the journal is face mask ventilation and vocal cord angle following neuromuscular blockade. And it is a prospective observational study. The name of the authors of this article are M.K. Lee, K.N. Kim, M.A. Jeong, S.Y. Kim, M.S.O. and B.S. Kwon. It was published in the journal Anesthesia in 2022. First of all, coming to the introduction part. During induction of anesthesia, face mask ventilation is widely used to ventilate the lungs of apneic patients. Several studies have demonstrated improved face mask ventilation after neuromuscular blockade, although improved airway patency or pulmonary compliance and a resolution of laryngospasm have been suggested as possible causes, the exact mechanism still remains unclear. Since neuromuscular blockade paralyzes the laryngeal adductor muscles and opens the vocal cords, the improvement in face mask ventilation after administration of neuromuscular blocking drugs might be associated with further opening of the vocal cords. However, no study has assessed the correlation between the change in the vocal cord angle and tidal volume after neuromuscular blockade. Hence, a prospective observational study was conducted to evaluate the changes in the tidal volume after administration of neuromuscular blockade and assess its correlation with changes in the vocal cord angle.
Yeah, Rushal.
Yes, sir.
Now we'll go step by step. So if you can go to the first slide, actually, from where you started. So please go back to the first slide. So it's also the previous one, title slide. Yeah, thank you. So it's always important for you to also look at the title. So what it conveys. So can you just inform me what all is information you can gain from the title itself?
So first of all, it is a study between the correlationship. It is a study between the correlationship of face mask ventilation and the vocal cord angle after the administration of neuromuscular blockade, and it is a prospective observational study.
Okay, no, I just restricted to the title. You added some details which you got later. Anyway, so just to convey to you, so when you look at the title, it conveys certain important parameters related to the current research. So that's also you should be trying to analyze. So what we are trying to discuss today is to critically analyze the publication. Indirectly, that also reflects the research methodology and how they have taken the study forward. So the title itself would convey some important factors. For example, we call it, for example, as PICOT. For example, whichever the patient population or the sample that is used, what is the intervention, what is outcome they are trying to study, and the timelines of the methodology. And majority of the times, we also want the design of the study to be part of the title. So if you can see here, they have talked about the intervention. Intervention, even though it is an observational study, indirectly you can link it to intervention. What is done is they are using face mask ventilation. What outcome they are studying primarily, most important is the vocal cord angle. And in terms of the technique, this is after the neuromuscular blockade is used for the patients. And it's a prospective observational study in terms of the design. So I just wanted to convey that in the title itself, we can always know the design of the study and the what they are studying, which set of population they are studying, and what are the outcome parameters they are studying. So this is important when you talk about the names of these authors. So this looks like a Korean article. Okay. So some of this research is broadly applicable to all the population across the world. Sometimes there are some demographic studies which are basically more focal and probably more practically applicable to some of these demographic parameters. So especially not just here, many times you would have heard us talking about the airway related articles otherwise also, where we talk about predictors of difficult ventilation and airway and other things. So they always say that we conducted this in this particular group of population, whether it is applicable to Indian population or not. It is. So that's the one question they ask. So next slide, please. So introduction. So what would you want to understand in an introduction, basically, in any research? Any one of you can take the question, Kushal and your friend.
So in the introduction, basically, we have to see what were the concerns, what were the issues that led to this study, what was the cause to study, whether it was important to study this topic, on whether there were previous studies conducted, what was the reason behind this topic, why this study was conducted.
Okay, so simply put, what is known already about this topic? Okay, if you carefully read through all the sentences which you have pasted here, they would have written about what is known already about the topic. So what they have written is during induction, face mask ventilation is used, but sometimes there is problem in terms of whether we are able to ventilate the patient properly or not, and with or without neuromuscular blockade. The same thing has been represented there. And what is the knowledge gap? So what is not known? So what they have written is, for example, in the fourth PowerPoint, they have written no study has assessed the correlation between change in vocal cord angle and the tidal volume of the neuromuscular blockade. So this is the knowledge gap and what they want to find and how they want to find out. So this is broadly the background or what is known already about a particular research subject or topic, what is not known or what is called the knowledge gap, and what they intend to do and how they intend to do in terms of certain basic parameters also. So this is always done with the citation of references. Okay, so because you have typed in a slide in the original article, there are citations of the references from which these points have been taken. Okay, so
Yes,
it is better to retain the citations for each of these points, whatever is there in the original article. Okay, so this is what I wanted to convey.
Methodology. This study was conducted at the Hanyang University Seoul Hospital between April 2019 to September 2019. All the patients provided written informed consent before surgery. The inclusion criteria for this study were the patients aged between 20 to 65 years of age group, ASA physical status 1 or 2, and who were scheduled for elective surgery under general anesthesia. The exclusion criteria of the study were history of difficult tracheal intubation, cervical instability, BMI of more than 30 kg per meter square, Malampati class 3 or 4, thyromental distance of less than 6 centimeters, mouth opening of less than 3 centimeters, cervical spine movement less than 45 degrees, full beard patient, OSA patients requiring treatment, restricted jaw protrusion, and there were also some secondary exclusion criteria, which were SpO2 less than 90% at any time during the intervention, duration of flexible bronchoscope manipulation more than 15 seconds, enactment of a patient's airway reflex, that is cough or laryngospasm, 50% reduction in tidal volume during flexible bronchoscope advancement, and tidal volume of less than 150 ml after confirmation of opened vocal cords. Coming to the implementation, before induction, 0.5 milligrams of atropine and 2 to 4 milligrams of midazolam was injected intramuscularly in the preoperative area. In the operating theater, a pillow 10 centimeters in height was placed under the patient's head. Standard monitoring was attached. An IV access was secured. Patients were pre-oxygenated with 100% oxygen for 3 minutes. The induction of anesthesia was done with initial bolus dose of 0.5 mg per kg, 1% lidocaine, and 1.5 to 2 mg per kg propofol with 0.1 micrograms per kg per minute remifentanil infusion continuously. Oropharyngeal airway was inserted. One anesthetist applied the face mask. Another anesthetist inserted a flexible bronchoscope through a custom-made self-sealing diaphragm attached to the elbow connector of the breathing circuit. The flexible bronchoscope was advanced to the distal tip of the oropharyngeal airway. Positive pressure ventilation was then initiated and continued until tracheal intubation using pressure-controlled ventilation with a peak pressure of 15 centimeters of water and inspiratory to expiratory ratio of 1:1 and a frequency of 15 breaths per minute. After confirming the first 3 consecutive breaths, the flexible bronchoscope was advanced further to visualize the vocal cords. After securing a view of the vocal cords, measurements were collected during 3 consecutive breaths. This was followed by administering 0.6 mg per kg rocuronium. After qualitatively confirming a TOF count of 0, another 3 consecutive breaths were used for measurements. The former and latter time points were defined as before and after neuromuscular blockade administration, respectively. Tidal volumes during 3 consecutive breaths displayed on the ventilator screen were recorded before and after neuromuscular blockade. The mean of these 3 readings was calculated and divided by the patient's ideal body weight. An image of the vocal cords before and after neuromuscular blockade was captured at the end of the expiration of the first of 3 consecutive breaths. After the end of the study, one assistant researcher who was blinded to the results measured the vocal cord angle. This is the image of flexible bronchoscopy of 3 representative patients during face mask ventilation. The first, the left and right correspondingly respond to the left images in the left side. These represent the the angle of the vocal cord before the administration of the neuromuscular blocker, whereas these images in the right side represent the angle of the vocal cord after the administration of neuromuscular blocking agent. A yellow dot anterior commissure at the vocal cord of the vocal cords, and two blue dots at the other ends of the vocal cords, and a dotted red line were drawn to facilitate accurate measurements of vocal cord angle. These patients were classified into three categories. First was complete closure, second was partial closure, and third was the open group. In the patients with complete closure, the angle before administering the neuromuscular blockade was 0 degree, whereas it changed to 24 degrees after the administration of neuromuscular blocking agent. Similarly, in partial closure group, before administration of neuromuscular blockade, the angle was 17 degrees, which further changed to 28 degrees after the administration of neuromuscular blocking agent. In the open group, the angle before administration of neuromuscular blocker was 25 degrees, which remained 25 degrees even after administration of neuromuscular blocking agent. So, as we have discussed, the patients were classified into three categories according to vocal cord status before neuromuscular blockade. Complete closure, vocal cords completely closed before neuromuscular blockade and fully open after neuromuscular blockade, an angle of less than 5 degrees before neuromuscular blockade. This group came into complete closure category. Next, the partial closure, vocal cords partially open before neuromuscular blockade and fully open after neuromuscular blockade. More than 5 degrees before neuromuscular blockade with a change in the opening of more than 2 degrees after neuromuscular blockade. Open. Vocal cords fully open throughout the induction process, an angle of more than 5 degrees before neuromuscular blockade, in which the increase in angle was less than 2 degrees after neuromuscular blockade. So this was the major difference between the partial closure and the open group, that a change in the opening of more than 2 degrees was after neuromuscular blockade was considered to be in the partial closure group, whereas the increase in angle where less than 2 degrees after neuromuscular blockade was considered to be in the open group. Now coming to primary outcome and secondary outcome of the study. The primary outcome was the change in the mean tidal volume after neuromuscular blockade, which was confirmed with a peripheral nerve stimulator. Secondary outcome, vocal cord angle before and after neuromuscular blockade and its correlation with the change in mean tidal volume.
Yeah, go to your methodology slide, the first one. Right, so in this, if you have to critique the methodology, what do you find is kind of different here? Something which you don't see usually? Would you like to answer?
Ma'am,
either of the two students? Yeah.
Ma'am, they have excluded all the difficult airway, all the predictors of difficult airway out.
Yeah, that's okay. That is how they choose to do it, right? That is how they're defining their patient population, which is all right. Do you see something called secondary exclusion criteria? Any comment on that?
Ma'am, they have also chosen to exclude the patients that undergone any of these things during the intervention when flexible bronchoscopy was being conducted intraoperatively.
So, right. So is there anything, truly speaking, I mean, if we have to critique, is there something called secondary exclusion criteria? Once you have taken in a patient and you have started your intervention, whatever it is, should you ideally be excluding that patient for any reason from your analysis?
No, ma'am.
No. There is something called as, I mean, if it's an RCT, we say once randomized, always analyzed, right? That's something called intention to treat. Because let's say that you were doing this fiber optic and trying to see the vocal cords, and for some reason, you are not able to do the procedure. Can that happen in your normal clinical practice also? Yes, that is a disadvantage of the intervention which is going to remain. So ideally, these patients, once you have included, should not be excluded. And to the best of my knowledge, there is nothing called secondary exclusion criteria, but maybe other moderators might kind of know more about it. We can talk about it later, but this is not pragmatically very correct. So even if these were excluded, their data should have been retained and analyzed. So that's my first comment on this.
Yeah, I agree. For the larger PG group and the budding researchers here. So as far as my knowledge goes, as Dr. Tyagi says, it's not to be here. So it's basically what the inclusion and exclusion criteria are decided before you start the research.
Absolutely.
So whatever is putting the big fonts from you is the one which suits here. The small font, the second exclusion criteria is never heard of basically. And of course, this could be there, could have happened, but this would be part of some methodological things which they will discuss later on. So they would say at the end of methodology, during the course of the conduct of the study, when they do all these maneuvers, if there is a fall of SpO2 below 90%, we are going to do this, and if there is some desaturation, something like this. So all this data should have been there, not here, first of all. So technically it is not correct, and even academically it is not correct, basically because this has happened during the course of the methodology, which would happen at that point of time. And there are sample size considerations, as Dr. Tyagi was telling, because a certain sample size is predetermined before the start of the study. And this has to be accounted for in terms of the final sample which has been taken up and it is analyzed. And this is the next section, which probably at this point we'll not discuss. But surely this doesn't look nice to have it here. Thank you.
And next slide, can we see your sample size slide, please? Now here, the aim, next slide, please. You've skipped one, yeah. So the aim, they said, was to see the change in tidal volume and change in the vocal cord angle. So ideally, your sample size is calculated by the primary outcome measure, which should stem from your aim. If you look closely here, they talk about, yes, aim is correlation between two changes. Primary outcome measure, they have taken as change in tidal volume, correct? Now just go to the next slide. So for sample size, whatever the power, whatever the level of significance, for PGs, it's important to remember that the sample size has to be calculated according to primary outcome measure. And if you read the details of the study, you will find, and see, it's not mentioned here, the change in tidal volume or what was being seen, probably it's been skipped, because our residents kind of don't understand the importance of it. And that's why we are stressing it here. So if the primary outcome measure was a change in tidal volume, the sample size should have been calculated for the same. If you see the detailed paper, it does not calculate it for the change in tidal volume. It calculates it for a certain tidal volume. And the conclusion is, or the results are, a correlation between tidal volume and vocal cord analysis. So this becomes a little questionable. Carry home for residents that your primary outcome measure should be used to calculate sample size, which should stem from your aim. So I don't kind of really agree with this calculation here.
Yeah, I'll have a small comment here. Again, definitely it is perfect as you told. And number two, maybe you may not have too much of details about all this sample size calculation. When they talk about a power of 90%, they cannot talk about that alpha of 0.05. Okay, that's one thing which is not correct. So 90, it would be 80 versus 0.05. If it is 90, it would become 0.1. So whether it is, do you agree, Dr. Asha? The simple thing.
No, sir. I mean, you can have a difference in both, in the sense power is your related to beta error and alpha is alpha error. So we can have traditionally alpha error we hold at 0.05, and a power minimum acceptable is 80%. Yes, you can go up to 90%. Your sample size would go higher. If you are looking for a 0.01 alpha error, then that would mean that the traditional 5% p-value that you're looking for will actually, you'll be reading it off as less than 1%. That's my understanding of the alpha and beta errors.
So anyway, it is not straightforward. So from my knowledge, I would say this alpha relationship with the beta error doesn't appear to be well thought out. And of course, I go with your correct suggestion that primary outcome is always used for assessing the sample size.
Sample size, yes.
Yeah. So now we can go back to that slide, please. That inclusion, exclusion. And of course, what is presented by the PGs is that. But I went back to the printout, the soft copy of the article. I found something missing in the beginning of the methodology. Can you just tell me? So in the published material which you have read and shared, so first thing is okay. It was conducted in such and such a hospital between such and such duration, and patient provided written informed consent. So this is also perfect. You think anything is missing?
Sir, clearance from the ethical committee.
Yes, that is one thing. So I didn't find in the material.
Registration.
Did you find or did I miss?
No, it's not there. It's not there. Even I looked for it. The ethical clearance is not stated. Trial registration is not stated. Although we could kind of argue whether it's a trial or not, but it's not even stated.
Yeah. So it must be.
It is stated in the acknowledgement, I guess.
Yeah.
In the acknowledgement part, ma'am, it is written.
So it's yeah. So
I have one question, Dr. Bala and Dr. Asha.
Please.
Yeah, I've been actually picking up points as you have explained, but I'm a complete clinician and I don't know if I dozed off, but what I understood was a face mask was held by a person A and a person 2 put the bronchoscope and the tidal volume is measured. Isn't the tidal volume measured related to how effective a face mask is being held? And thereby a tidal volume less than 150 can happen with a poor mask fit as well. So, excluding this, how accurate is this? I mean, this is not statistics, but I'm a clinician and I'm wondering, either I've missed something in the part of the presentation, I have not read through the article.
No,
Does this strike you as well?
Yes, it did. And actually, if you look at the methodology in the next slide, it is not even mentioned as to how they maintained the anesthesia while they were holding the face mask. It's just not mentioned anywhere.
Would remifentanil as an infusion give that state of anesthesia? I mean, I haven't used it.
I doubt it.
Okay.
I mean, you need, they haven't commented on the percentage of oxygen. They haven't commented whether it was air or nitrous oxide. And on the other hand, we are excluding patients with a saturation of less than 90%. So that should have been standardized probably. And you're very right about the 150 ml comment also. And although they say, all right, that is just one particular person holding the mask every time, and they are averaging 3 tidal breaths, but then this as an exclusion again. Yeah, I agree.
Okay.
So even when we talk about standard research, so which is related to airway, and you talk in terms of face mask ventilation, I found it surprising that they never spoke about using the right-sized mask in the beginning. So they have talked about 3 minutes of pre-oxygenation. If you read through the article, they have written about 3 minutes of pre-oxygenation, but that's it. They are not talked about, yes, Dr. Asha is talking about. Nothing is given in terms of, as an average researcher, what we would always talk about is the sized mask would be used for a particular individual. So you cannot have a uniform mask for everybody. So that should have been mentioned, or later on in the publication, they could have commented upon these things. This has not been there basically. And they have talked about putting an adapter to pass the fiber optic scope inside. Whether it was purely a single mask or an adapter which could be attached to different types of masks for different patients, those details are not available. So this is probably one thing which I also noticed, just like Dr. Lekshmi has asked. So authors have to talk about this. This is one thing. And anyway, small strange things were again, there is a mention of IM atropine and IM midazolam and starting of an IV line inside the operation theatre. This I found it a little bit strange here.
Giving an IM injection in an adult seems unnecessary when you can so comfortably place an IV.
And 2 to 4 milligram, and when we can very easily place a IV line and from a bigger hospital. So this is the one which is also liable for some sort of criticism from our side. So again, there was mention of this positive pressure ventilation. So with remifentanil and propofol, of course, there is no mention of gas or air alone with oxygen. Any comments, Dr. Lekshmi and Dr. Tyagi, about this? With a patient just under anesthesia.
Yes, please, Dr.
Yeah, so they have said that once the vocal cords were visualized and 3 readings were taken, they have given relaxant, rocuronium 0.6.
This is before that.
Pardon me?
This part is before the administration of rocuronium.
Yes.
They straight away, I think they have mentioned about using the positive pressure ventilation after induction, before administration of rocuronium.
They've started the mechanical ventilation using PCV mode immediately after the induction, and then after visualization of the vocal cords, they've continued that with the relaxant. That's what they have done. So PCV itself actually, although in all fairness, the authors do discuss this in the discussion also, but it had struck me that when you are using a pressure controlled ventilation, it is bound to affect the vocal cords itself also. So we are measuring the angle, and this is likely to be a confounding variable. And we are using a constant pressure of 15 in all patients, irrespective of what tidal volume is being achieved. These observations are in addition to those being made by Dr. Bala, sir, that of course to expect the patient with just propofol and remifentanil and be able to ventilate with PCV, I don't know how effective this would have been.
Right.
I think you brought that point of confounding variables, so I would want the PGs to understand it. So there will be, please go ahead, explain.
So actually, see, when confounding variables are something which can be dealt with at 2 stages of your study, and they're very important because this is an external variable which is going to affect, let's say, what we said is your outcome measure, primary outcome measure. Let's just stick to primary outcome measure and remember that you are trying to study the effect of X on your outcome measure, but there is something else Y which is different in each of your patients, and that itself is also going to affect. So these confounding variables can be kind of controlled in 2 ways. One is that let's randomize them into groups. Let's randomize patients, and I will hope that the confounding variable is now equally distributed. May not happen. The second is that at your stage of statistical analysis, if you kind of approach a good biostatistician, they can control it in your statistical analysis also. I don't want to complicate it by going into regression or whatever, but just remember that a good, well-designed study must think of confounding variables at the designing stage itself. So that's all I'd like to put in.
Yeah. So this is an important one, basically, for, of course, we are seeing it now. And what I would like to convey is, even in a methodology section, whatever technique is being followed and what are the outcomes are considered. So what is expected to be there in the published article is what were the definitions which they have used in relation to the outcomes, whether it is primary or secondary, any classifications which they have used in terms of all these assessments. So these must be clearly mentioned by them, and wherever necessary, there can be these graphical examples as they are given here, and sometimes even there could be some video support, so which will help in assessing this. Video, when I say video, it is normally provided as an online access, not in the print, of course. So we can go to the online versions and look at those videos also. So this would be in terms of the technique of anesthesia or any research methodology. For example, I am giving a new type of block, so I should be able to display it clearly, new one. Now, I am not going to talk about spinal anesthesia and again describe everything. So anything new, it is ideal that you describe the procedure in detail, give graphical display, then if possible, if necessary, if suitable, some video also, and then discuss. And in terms of some gradations, so what they have done is they have provided some sort of classifications here. What is complete, what is partial closure, what is totally open. This is also very well done in this particular publication. So we have to look for all these things. If they had not given this, so we'll be just imagining things, and definitely our research and the take home will not be good also. So please make sure that these points are also considered in terms of the technicalities and the implementation of the methodology. Yeah. So as already discussed by Dr. Tyagi, and we must always have a single most important outcome, which also helps in determining the sample size. And the secondary outcomes would be multiple. So if you later on read in the article, they are given different other parameters also in terms of secondary outcomes. So that includes certain correlations of the angle with tidal volume and other things, and some adverse events which may also occur. So that could also some hemodynamic events otherwise in certain other cases. And majority of the cases, whenever we use drugs, not this case, I mean research alone, we use many drugs. So normally under anesthesia and critical care, we talk about the hemodynamic changes. Then we talk about, post-operative nausea and vomiting. So these are all generally in the secondary outcomes.
Now coming to the statistics part. A sample of 108 patients achieved a power of 90% and a two-tailed alpha that was 0.05, considering a 10% dropout rate. A paired t-test was used to compare the changes in the mean tidal volume using PASS version 16. Mean tidal volume and vocal cord angle before and after neuromuscular blockade were compared using a paired t-test. Assessment of normality was conducted using the Shapiro-Wilk test. The incidence of insufficient ventilation according to vocal cord status was compared using Fisher's exact test. The correlation of the proportional change in mean tidal volume with that of the vocal cord angle after neuromuscular blockade and the mean tidal volume with the vocal cord angle before neuromuscular blockade were analyzed using Pearson's R or Spearman's Q after assessment of normality. The influence of each variable, that is age, sex, smoking, asthma, on complete vocal cord closure found during univariable analysis was evaluated by stepwise multivariable linear regression analysis. Variables with the p-value of less than 0.05 were entered into multivariable analysis, and the exclusion criteria for inputting the variables of the multivariable analysis was p-value of more than 0.10.
Okay. Any comments, Dr. Asha? I'm pushing all the statistics related things to you.
Yes,
Kensha,
yes. I want to see this. I'm not. I hope I will not make a mistake. But whatever I know, yes, I'm willing to discuss.
Purely for the PGs, right?
Yes. Yeah. So here, both the students. See, you talked about the aim was to study a correlation between change in tidal volume and change in vocal cord angle. Now look at your statistics slide. Does it tell you how that is going to be done? That is the most important thing. So in this jargon of all the tests, never lose sight of the original aim and comparison. For that, in the results, you will see that they have done a correlation testing, but that needed to be here, first thing. Second, when calculating the sample size, the outcome measure for which you are calculating the sample size should have been written by you. It is there in the original article. Third thing, what do you need a paired t-test for? Since Journal Club is also to kind of understand research, so I'm taking the liberty of just putting these in a simple one-liner. So whenever normal data, quantitative, you want to compare before and after an intervention, you use a paired t-test. If it was not, let's say you're comparing age between two groups, it is continuous, numerical data, two groups, normally distributed, unpaired t-test. But now, if I wanted to compare the weight before and after, let's say, a different kind of diet in the same patient, it becomes a paired t-test. Third, you are talking about incidence of insufficient ventilation here, but you didn't define that in the methodology. So let's be consistent, starting from the aim to the objectives, to the outcome measures, to your statistics. Everything has to follow a line. That would be my first thing. And correlation should have been mentioned here because that was the primary aim.
So normally, just to strengthen what is being discussed now, so in majority of the publication, a standard and average publication, there would be mention of the broad categorization, even though we do understand it later. So broadly, there will be mention of the categorical variables, otherwise called as qualitative variables, and numerical variables. So they would have mentioned. So numerical is also called quantitative, where we talk purely in terms of numbers, right? So that is one thing. And when you talk about category, normally, basically they are in terms of certain percentages and ratios. So these will be clearly mentioned, and they would then say we use this particular type of variables, and for these particular variables, this type of statistical tests were applied. So these are the statements that is made. So I don't say that you need to understand everything, but broadly you are expected to understand the classification of the outcome variables. So in terms of blood pressure, in terms of percentage of patients who had improvement in the angle of the vocal cords and other things. So this is one thing you have to please remember. And overall, as you go forward in your career, probably you'll understand better.
Now we'll discuss the results here. First of all, 161 patients were considered eligible for the study, out of which 53 patients were excluded on the basis that 39 patients did not meet the inclusion criteria and 14 patients did not give consent for the study. So 108 patients were enrolled in total, out of which during the procedure, 8 patients were excluded on the basis that 6 patients fell in the category that duration of flexible bronchoscope placement was more than 15 seconds, and in 2 patients, airway reflexes were enacted during flexible bronchoscope, that is cough and laryngospasm. So in total, 100 patients were analyzed in the end of the study.
100 only?
Yes, sir. Sir, the secondary criterion exclusion, that means the dropout rate was 8 on the basis that 6 patients in which flexible bronchoscopy extended for more than 15 seconds and 2 showed airway reflexes.
No,
so
just if you go back to the sample size slide, no?
Yes.
So I have mentioned about purely 108 patients. So when it is about 108 patients shall be there.
No, but they're saying that considering a 10% dropout rate, they have taken 108. So
98 is adequate.
Probably right. That's what they mean.
Okay. Agree. So PGs, what you have to understand is, so this 108 patients is inclusive of 10% dropout rate. So this we can go to that flow diagram now. So approximately now they have lost about 8 patients, right?
So it's all right. Yeah.
Looks all right at this point of time. So please remember that dropouts are always accounted for about 10 to 15%. 10% on average is added to the calculated sample size so that the statistical tests have some better validity. Right.
Yes, sir.
Thank you.
This table shows the characteristics of patients receiving face mask ventilation during induction of anesthesia. So firstly, there are some demographic parameters like age, for which the mean was 45.3. Sex, 35 patients were male, and height, 163.8 centimeter was the mean for height. Weight, 63.6 kgs was mean for weight, and 23.6 kg per meter square was the mean BMI. In this, they also talked about the parameters that the patients were ASA class 1 or class 2, in which 69 were ASA class 1 and 31% were ASA class 2, and Mallampatti grade 1 was seen in 45 patients and 55 patients showed Mallampatti grade 2. Then there are other parameters for airway assessment like thyromental distance, cervical spine movement in degrees, and mouth opening, which showed that 7.3 centimeter was the mean thyromental distance seen in 100 patients. 51.1 degrees was the cervical spine movement in average, and 4.2 centimeter was the average mouth opening. So the significant values were seen in which the mean tidal volume was significantly increased from 11 milliliter per kg to 13.6 milliliter per kg after neuromuscular blockade and showed a p-value less than 0.001, which makes it significant. Tidal volume demonstrated a maximal increase after neuromuscular blockade in the complete closure group, that is 5.8 versus 13.8 milliliter per kg, followed by the partial closure group in which 12.4 versus 13.9 milliliter per kg was seen, and lastly the open group in which 12.3 versus 12.8 milliliter per kg was seen. A significant increase in mean vocal cord angle occurred from 17 degrees to 26 degrees after neuromuscular blockade. The incidence of insufficient ventilation was associated with complete closure of the vocal cords. All patients whose lungs were insufficiently ventilated experienced sufficient ventilation after neuromuscular blockade. Here is a table showing the number of showing the status of vocal cords and the sufficiency of ventilation before neuromuscular blockade. And then the incomplete closure group includes, there are two main groups, complete closure and incomplete. The incomplete closure group now includes open and the partial closure group both. So we can see that the complete closure group, there was 60% patients showing sufficient ventilation and 40% showed insufficient ventilation, while in incomplete closure group, 100% patients showed sufficient ventilation.
Because you didn't read through the last 3 lines, basically. There is a history of snoring in 33%. So when you talk about an airway, basically, even though you have talked about the patients who are obese not being included, this is one thing which should strike your mind. And probably, we don't know, we can go to the discussion later on, whether they have discussed about this aspect. Okay, snoring in 33% in the sample population would appear to be slightly a surprising number, right? That's what I noticed. And maybe there may or may not be implications for the current study, which can be basically discussed based on the outcomes. If they have indeed tried to correlate, that they have not done. Okay, have they done some? Yeah, so that sub-analysis could also have been done. So they have not included obese patients. Again, I'm restating that is true, but still having 33% of patients having a snoring history. So what are the implications of this has not been discussed. Later on, I have checked it already, and they have not tried to correlate this with the findings during the procedure, right? So next slide. Yes. Next one, please. Yeah. So this is about the closure. Yeah. So we have talked about the complete closure and other things. Only one small doubt I had this here was, because this is only a sample size of 100 approximately. So is there any data? Because this is a critical analysis. So this can come to my mind. Even otherwise, in a normal management of general anesthesia in any patient, how many of the patients would have, for example, closure of the glottis after induction? So this is one thing that strikes my mind when I analyze, and I will wait for any discussion points in this particular publication. So one thing which I noticed.
Yes. Now, again, I have the same question. Where is the result regarding the aim that you started with? You said you wanted to, the author said that they needed to see the correlation between change in tidal volume and change in vocal cord angle. It is there in the paper. Yeah.
Yeah, they are not projected, I suppose.
But
you have all those graphs here.
So actually, this is a good point to make regarding the study itself. When you read the study, maybe it's secondary to a language barrier. That's what I could kind of understand, that maybe it's been translated from Korean for the authors who are not familiar with the language. The flow of the study is very broken. Two main things in results you'll observe. The primary outcome measure, the first line comes in, mean tidal volume increase from this to this, but they don't talk about the change per se as a percentage. Secondly, the main aim results are given in the end of the results section as a scatter diagram with a correlation. Third, if you go back to your slide, somewhere you mentioned that you talked about a univariate and multivariate regression analysis between snoring, asthma, and something. Here, see, look at this last para of statistics. They are trying to see the prediction of vocal cord closure with these 4 variables. But nowhere is this mentioned in the methodology as an observation. It was not on their mind, or probably it is not documented. And in your results section, you'll find that suddenly this has come before the primary aim. So these are things which you have to be very careful about when you are putting your results on paper. So not so much missing from your side, but paper also did not kind of word it very clearly, and you have also ended up missing out the primary aim results. Next, please. And that's all. That is the only comment.
So you have missed some of those graphs being displayed. So I think about 2 to 3 graphs are there. So no problem. You please go ahead. But one more topic. Please read through.
Yes, significant improvement in face mask ventilation and increased vocal cord angle after neuromuscular blockade was seen. Insufficiency of ventilation and increase in tidal volume were correlated with vocal cord angle. Results reveal 2 important principles. Number 1, along with well-known airway structures such as tongue, epiglottis, soft palate, the vocal cords must be considered a potential cause of airway obstruction because their adduction leads to poor face mask ventilation. In patients with normal airways, neuromuscular blockade seems beneficial rather than risky, as can be seen from numerous studies that confirmed improvements in face mask ventilation after neuromuscular blockade. Determining whether to intubate a patient's trachea after induction of anesthesia, checking face mask ventilation before administering neuromuscular blocking drugs was thought to improve safe airway management, and it is a common practice as we follow. However, this study demonstrates that vocal cord closure can produce difficult face mask ventilation. Therefore, checking face mask ventilation before neuromuscular blocking drug administration is likely futile unless patients already have open vocal cords. Instead, omitting to check face mask ventilation and early administration of neuromuscular blocking drugs in patients with normal airways may achieve earlier adequate ventilation and earlier tracheal intubation. There were some limitations discussed here. The findings could not be generalized to predicted difficult airways. There was no control group in the study. It could not distinguish the effect of anesthetic depth from that of neuromuscular blockade, and it needs a larger study population and a well-designed randomized controlled trial to generalize the results.
So in fact, I think discussion is good overall. They have accepted the limitations of the study in that aspect. And for example, in this PowerPoint 3 in this slide, so they have talked about the other variables which would affect, for example, neuromuscular blockade, then patients with poor face mask ventilation, and sometimes it could be the patients who have some physiological changes, not anatomical. So that's the reason I said that obesity is ruled out, but they are talking about snoring in about 33% of patients. So I would have been happy if they had discussed this small point here in the discussion. So there was an incidental detection of 33% of the patients being snorers, and a small discussion about any implications related to snoring and any hypotonia of the muscles or the pharynx, and do they affect the angle of the vocal cords and the amount of opening. So this discussion is missing. This was one of my observations. Next.
I have a small comment on this. Because next slide, please.
Yeah.
Next. Now, if the carry home message from the discussion is going to be that let us start using muscle relaxants without checking for successful bag mask ventilation, in patients with normal airway. That's what they are saying in these first two lines, correct? Maybe that, because we are critiquing the study, that may not be correct to infer from their findings. To say that I can not give or give a muscle relaxant and have a different success rate of ventilation should ideally be commented only if you have an adequately powered RCT, in which one, you give the muscle relaxant, in the other, without check ventilating, right? And in the other, you don't. And then you compare the incidence. So this may be a little far-fetched and early to kind of conclude this. So although they do discuss this as a limitation, yes. And secondly, as far as that non-successful ventilation, as Dr. Bala was also pointing out earlier, that in clinical practice, we don't really end up not being able to ventilate before a muscle relaxant, right? They say 40% they could not ventilate. I think that is also because they were using a predetermined pressure of 15 centimeter water only. What if my patient's compliance is low and I need to augment the pressure? So when we normally ventilate, we just increase the airway pressure, the ventilating pressures, which they were not doing. So again, to conclude that a closed glottis means that you will not be able to ventilate is true when I'm using a PCV of 15 centimeter of water. Otherwise, it is not true. So to validate these findings in routine clinical practice may not ultimately prove to be successful. But yes, the idea is very interesting and it is a new concept. And to even think about vocal cord closure as a cause, barring laryngospasm, yes, that was interesting to know.
In conclusion, tidal volume and vocal cord angle during induction of anesthesia increased after neuromuscular blockade in patients with normal airways. Both insufficiency of ventilation before neuromuscular blockade and improvement after neuromuscular blockade were correlated with vocal cord angle. Acknowledgement. This study was approved by the Hanyang University Institutional Review Board and prospectively registered with the Clinical Research Informational Service. No competing interests were declared. Here are the various references for the study, which validate the points made in the study in documented forms.
So this section, so good thing you included this part also. It's always better to know about the references. Sometimes because of constraints of word count, which is required for publication, too many details won't be there. And you may have some doubts also. You can always go to these references and clear your doubts. So this is the way the publication has to be read. So I think Dr. Sanish, we can go to the next.
Okay, and thank you very much, our postgraduates from DMCH Ludhiana. You can stop share now.
Thanks.
Okay. So I hope everybody is enjoying the first Journal Club edition of ICA PG Assembly. We would like to hear what you think about the format of the program and how useful it is and how best we can modify for the subsequent editions. I think if you are missing the whole picture while discussing a particular article, do look into the abstract which is provided along with the webinar flyer. Because of the copyright issues, we will not be able to send the full text articles. So moving ahead to the second part, I would like to invite Dr. Kritika and Dr. Varshini from Amrita Institute of Medical Sciences, Kochi, Kerala. They'll be presenting an article from BMC Anesthesiology. It's over to Dr. Kritika and Dr. Varshini.
So a very good evening to everyone, to all the faculties and the colleagues. Today we have selected a topic, analgesia and spread of erector spinae plane block in breast cancer surgeries, a randomized controlled trial. I am Dr. Kritika and she is Dr. Varshini from Amrita Institute of Medical Sciences. In our institute, we are doing a lot of erector spinae blocks, both single shot blocks and catheter placement is also done for mostly breast cancer surgeries and for liver surgeries. So that created an interest on further knowing about the study. still a conflict of the volume of drug used, whether a higher volume causes more spread, has been a point of interest among us. So that made us select this study. And going on to the study, this is an article published in BMC Anesthesiology. The authors were Ahmed, Imad, Nagwa, Besam, and Walid. It was published on 17th October 22 from the Department of Anesthesia and Pain Management, Medical Research Institute, University of Alexandria, Egypt. The duration of study was between March 2021 to January 2021. So a quick go through of the abstract. The background was to evaluate the analgesic efficacy and spread of variable volumes of local anesthetics in erector spinae block. Methods, 60 patients aged between 18 and 50 years with AAC 1 and 2 and scheduled for breast cancer surgery were randomized to receive either ESPB with 20 ml of 0.25% bupivacaine, that is a standard volume ESPB, or with 40 ml of 0.125% bupivacaine, high volume ESPB, or no ESPB, GA only group. The primary outcome was pain intensity evaluated by the visual analog scale 12 hours after the surgery. A p-value of less than 0.05 were considered the cutoff point for statistical significance. The secondary outcomes were pain at rest and pain on movement evaluated by the VAS, craniocaudal injectate spread to paravertebral space and epidural space assessed by CT, clinical dermatomal spread, level of sedation or agitation, and patient satisfaction with anesthesia and analgesia. The results were VAS at rest 12 hours after surgery was less in both intervention group compared to the control group. The LA had extended further in high volume group than the standard volume group. No difference of the spread to paravertebral or epidural space between the two intervention groups. And more dermatomes were covered in the higher volume group, and agitation was higher in the GA only group than both ESPB groups in the first 8 postoperative hours. Patients were more satisfied in both ESPB groups than the GA only group. So they concluded saying preoperative ESPB is an excellent analgesic modality and it can also attenuate both postoperative agitation and sedation. But doubling the injectate volume enhances the craniocaudal spreading and may be useful for surgeries requiring multiple dermatomes. However, a larger volume has no effect on analgesic efficacy or patient satisfaction as there is no further spread to the paravertebral, epidural, or spinal nerve rami. So going through the study, the background and aims. The background was to evaluate the analgesic efficacy and spread of variable volumes of local anesthetics in erector spinae plane blocks for breast surgery for malignancy. The hypothesis was preoperatively high volume ESPB leads to, we all thought that it leads to better postoperative analgesia, less agitation, less sedation, and higher levels of satisfaction. That is probably due to more extensive LA spread than the standard volume. So the primary outcome was pain intensity evaluated by the visual analog scale 12 hours after the surgery, and the secondary outcome was pain at rest and pain on movement that is evaluated by the VAS, and craniocaudal injectate spread to the paravertebral epidural space assessed by the CT, clinical dermatomal spread, level of sedation or agitation, patient satisfaction with anesthesia and analgesia. Coming to methodology, it is a prospective randomized.
Yes, do the moderators want to ask anything at this point? Asha and Dr. Bala Bhaskar?
Yeah. See, that's why we'll stop at this stage. So you can go back to.
Kritika, move to one slide before.
Yeah.
No, yeah.
I think this is your slide in the sense you have just picked up. Or is it pasted straight away? This particular slide?
It is from the study. From the study. From the article only.
Okay. So because if you look at the title here, no, slide title, you have mentioned as background and use. Actually, there is no background in this particular slide. So it is there in the article per se. That's why I asked. In the abstract, they have failed to mention about the background. Right?
Yeah, yes. They have failed to mention.
So as I told you with the previous session, So background is whatever is known already in this particular ESP and what is the lacuna in the current knowledge, and what they want to do. So they have only talked about what they want to do, and they have missed about talking the background in the abstract also. That's also important and required mandatorily in an abstract. Okay, this is so that we have to note basically, and with various references, as I told you already, there must be clear references of the various published articles in support of their claim. Okay, this is the first one.
Okay.
Yeah, and they have talked. This is the background and links. So I also went through the article. So the first point appears to be on the face of it very simple: pain intensity evaluated by the visual analog scale, 12 hours after surgery. Okay.
Yes.
So overall, the article is well done. Otherwise, but even I would want them to be more specific here of pain at rest or pain on movement or pain on respiration. Okay. So even in
they said it is pain at rest. Is that correct? Kritika and Varshini, did they mention pain at rest?
They have mentioned later on, madam.
Yes, ma'am. Yes, ma'am.
No, second. That's the reason. Only at this point, you go to the secondary outcomes. What they have written is pain at rest and pain on movement at 1 hour, 2 hours, 3, 4, 5, 6, 8, and then just keep to the 12 hours aspect. So very well, they could have said that it is a primary outcome was the pain at rest evaluated at 12 hours. So that mention of pain at rest is not there under primary outcomes. That's the only thing. But they have to be correct. Everything must be clear. And in terms of the secondary outcomes, pain at rest and pain on movement is also mentioned. So first of all, I have some reservation on using this BOSS as a phrase. Basically, it is ideally advised to be used as a numeric rating scale. This mainly for the postgraduates. Not that the technique is wrong and the whole methodology is wrong. So the current practice is to talk mainly about a numeric rating scale. So VAS would be mainly in the form of patients who will not understand, you will not be able to respond to our queries scientifically in terms of what is the intensity of the pain and other things. So that is one small limitation which we may ignore also. That's not a thing. And one more thing I thought would be needed is the pain on breathing, on respiration. Okay, so even though it is a part of assessment of the outcome in certain major thoracic procedures, why this should not be included as part of the secondary outcomes here also? After all, if somebody is breathing and wants to take a deep breath, and there is a broad scar on the, incision and a scar on the chest wall, they talk about the movement of the limbs. So upper limbs, when they talk about the movement, the pain. So, but it is always also advisable to note the pain with respiration and with cough. So of course, we may at least ask about the pain with respiration. And when you go forward in the study, they have talked about the various dermatomes being affected. And definitely there is risk of some amount of weakness of intercostals if indeed there is a widespread of the drug. So this is the one thing I noted. Next slide, please.
So methodology, it is a prospective randomized controlled trial, and the ethical board was approved by the Institutional Review Board, Faculty of Medicine, Alexandria University, Egypt, and CTRI registration was done on the date of 12th of March 2021. Funding was provided by the Science and Technology and Innovation Funding Authority in cooperation with the Egyptian Knowledge Bank. The authors received no financial support for the research, but no details about obtaining informed consent was present in the study. Inclusion, study included patients with age of 18 to 50 years and belonging to ASA class 1 and 2 who were scheduled for the breast cancer surgeries. Exclusion criteria were allergy or contraindication to any of the studied medications or anesthetic agents, scoliosis or any vertebral anomalies of previous spinal surgeries, morbid obesity with a BMI of more than 40 kg per meter square, chronic opioid analgesic use, pregnancy, infection at the site of injection, duration of study for more than 90 minutes, and renal impairment. Coming to randomization, patients were randomly allocated using a computer-generated random table, and an allocation ratio of 1:1:1 was assigned to use the patients, but no mention of how allocation concealment was mentioned. So they have assessed around 80 patients, out of which 20 patients were excluded who were not meeting the inclusion criteria and declined to participate. So totally sample size were around 60, of which 20 patients were allocated to one intervention and 20 to another intervention and other interventions. So 3 interventions with each of 20 participants were done, and there were no loss to follow-up or who discontinued any intervention, and hence all 20 patients in each 3 groups were analyzed. The interventions used were a USD-guided Erector spinae plane block at T4 transverse level process with high volume ESPP group as group 1, which received general anesthesia with pre-induction block with 40 ml of 0.125% bupivacaine and 5 ml of radio contrast dye. The standard volume group received a GA with pre-induction block with 20 ml of 0.25% bupivacaine and 5 ml of radio contrast dye. And the control group received only GA, and for the purpose of blinding, the skin was infiltrated by the LA and the catheter was left above the skin. CT assessment was done 15 minutes after the block to look for the craniocaudal spread or paravertebral spread and epidural spread. But no mention about whether the control group had got a CT done. If yes, it is unethical exposing them to unnecessary radiation. Dermatomal spread was assessed 15 minutes after the block, but who did that was not mentioned in the study. Postoperative analgesia was provided with bupivacaine 50 mg with the same volume and concentration assigned to each group at the end of surgery, and was at 1, 2, 3, 4, 8, 16, and 20 and 24 hours after surgery was noted. It was assessed by a physician who was not involved in the study. IV morphine with patient-controlled analgesia was given as a bolus of 0.5 milligram per kg with a lockout interval of 10 minutes. 4 hourly, limiting dose was 10 mg. If VAS score was still more than 4, additional ketorolac 30 mg IV was given. The level of agitation was assessed by Richmond Agitation Sedation Scale, and the patient satisfaction were assessed by the Likert scale. Coming to blinding, it is a triple-blinded study, but in the absence of a primary anesthesia providers, a specialized regional anesthesia team had performed the regional blocks for the intervention groups in the designated block room and inserted catheter in all the patients. They have also performed a CT scan of the thoracic region, partially extending to the lower neck and the upper abdomen 15 minutes after the block. And the spread of the injected solution in the Erector spinae block was evaluated and interpreted by the same radiologist. In the post-anesthesia care unit, pain score, as with other measurements, were assessed by a physician who is not involved in the study design.
Can I ask a small question here? Now, in your methodology, you say in the inclusion criteria that patients undergoing breast surgery for malignancy.
Yes,
correct? Now, and the outcome measure is pain. So do you think the VAS score or the post-op pain is going to be different for different kind of breast cancer surgeries? Simple. If there is axillary dissection or not, then your block.
Yes, ma'am. It might be different.
Yes.
Different.
So would that be a confounding variable?
Yes, ma'am.
Yes. So have they tried to talk about that in the methodology at any stage?
No, ma'am.
So we'll come to it. They have addressed it. We'll see how they have addressed it later. Okay. And probably it's just a typographical error. The morphine dose should be 0.05 milligram per kg, I'm sure. Or did they use 0.5 mg per kg for post-op analgesia? This, go back. PCA bolus.
It was 0.5, ma'am.
It's 0.05. It's 0.05.
Should be 0.05. Yeah, it's okay. So good, you did not copy and paste. Excellent. Good. Okay, go on, please.
So, there was no mention about any intro of hemodynamics, because obviously in the control group, without any additional analgesic like ESBP block, there'll be definitely a change in the heart rate and BP pressure due to the pain. And there was also no mention of any intra bliss monitoring was used to assess the level of anesthesia, depth of anesthesia, and no mention about the intra opioid requirement was also not mentioned in this current study. So sample size was calculated as per a previous study.
Just hold on, you go back to the first methodology slide here. The sample size will again, it will be slightly different section.
Okay.
Yeah. This is the first one. Okay, anyway, this is not CPRI. Again, it's a typography from your side. It is clinicaltrials.gov, right? Registration.
Yes, sir. Yes, sir.
So that it's from another country and they are registered in clinicaltrials.gov basically. Okay. Yeah. Next, go to the exclusion criteria. Next one. So they have talked about chronic opioid analgesic use. Okay, so it could be any other analgesic, not just opioid, because this is an analgesia-related study.
Yes, sir.
Okay, so we should also be looking for, probably they have not mentioned, they have only talked about chronic opioid analgesic dose. Or if it is indeed acceptable to have some patient with analgesia also, that would apply to both the groups in a randomized control trial. So that is there, no problem. And they have talked about duration of surgery of more than 19 minutes not being considered. So would you be happy with this? Why should they be talking about the 90 minutes limitation for exclusion? No, does it strike? I mean, why you should be not happy? For example, I'm not happy for some reason based upon the methodology. So because they are talking about putting a ESP, then general anesthesia for the patient, and what would be the duration of action of an ESP block, right? So either they should have discussed in the discussion later on, or they should have even justified not including patients where duration of surgery is more than 90 minutes. Okay. So it may not be too pertinent, but even something entered here should be based on sound research methodology. Okay. So any drug, for example, if it is purely analgesia related technique, and if duration of analgesia with an ESP is more than 90 minutes, 120 minutes, 2 hours, 3 hours, there is no harm in including patients with the duration of surgery being more than 90 minutes also. Okay. Then what about the last exclusion criteria? Renal impairment. About that.
They haven't mentioned specifically about it in the discussions.
No, they have not mentioned. So we are critically analyzing. So anything from your side? So what they are using along with the drug?
Contrast.
So contrast they are using. Which contrast they are using?
ID. Radioide.
Okay, radioide. So it is iohexol which they are using. So it is safely used many times. All of us are there, but still one of the adverse events is
nephropathy.
Happen to the renal function. There is a risk of contrast
nephropathy.
Oh, good thing they have mentioned it. So if at all somebody really has got a background renal disease, it is advisable not to use it. Okay, so that's the reason they would have done that basically. And of course, the next slide, you have mentioned the next slide. Yeah, this allocation concealment has not been done. So they must have clearly mentioned, at least this is under their control. When the next few slides, there is something related to blinding and all, that's acceptable to some extent. But here allocation concealment was very much possible, but they have not properly done it and they have not mentioned it also. Okay. That's the one. Then in terms of interventions, only thing is you are also expected to expand on the details of ultrasound. Now it is there in the original article. So whenever we talk about ultrasound, this is one of the small things we miss out. We should also talk about that mention, even though it is as part of the critical analysis, the type of probe that is used right?
Okay.
The frequency which is applicable for this particular technique. Okay. So if, for example, something is new, so it's also important for them to convey to the reader.
Okay. Okay.
Small thing which just not added, that's all, but it is there in the original article, right?
Yes, sir.
So next slide, you have mentioned some of the limitations. Right? Did control group get the CT done? So definitely it's not done, it's not needed, but of course, if it is done also, it will be really unethical. Okay, nothing has been injected.
Yes.
Understand? So even otherwise, overall, they could have mentioned in the discussion part also that they did use CT to commit. They should commit that it is generally safe in the current day practice, but theoretically there could be some small ethical issues. But however, it was discussed and approval from the ethics committee was taken. Okay, and in terms of the dermatomal spread, I think the discussion part they have justified it, but it's a good thing that you have talked about it. Then in the post-op thing, the next slide, yes. So they have used too many drugs, basically, and different areas. And as I mentioned before, in the second point, see, I have written about VAS at 1, 2, 3, 4, 8, 16, 20, 24. That is secondary parameters. The primary one was the VAS at rest at 12 hours, basically. So they have taken forward the same type of presentation. That's not a problem. And then sedation per se, because they have kept it so uniform in both the groups, so you should be able to justify the need for assessment of the sedation aspect, because the patient was on morphine and again patient control analgesia, everything was already there in the patient. Then okay, next one, you also talked about, next slide, is over now. Okay, next. Okay, so what we have to understand is they are given a block in the preoperative period. They have waited for 15 minutes for the drug to spread. Then they have taken the patient for CT pictures, right? So that's what we put up here. So we should know that whoever has put the block, the drug that has been given or the group allocation should not be known to the radiologist. Yes, so that's what he wanted to convey.
Yes.
Right. So, physician not in the study design. Right. So next slide is you have talked about intra hemodynamics. So one more thing I want to highlight, you did talk about the important reasons for monitoring, but I would also say, because later on if you go to the results section, it will be there. They have talked about the drug being at risk of going into the paravertebral space, drug at risk of even going to epidural space. So this is all theoretically possible, and definitely there will be some risk of sympathetic blockade. So it is important that they should monitor and present the hemodynamics in the three groups. And of course, BIS monitoring, basic thing is missing. An intra-opioid requirement. Initially, in the block room, they are given about 0.5 mg per kg of fentanyl plus midazolam. Then before induction, they are given, I think, about 1 mg per kg of fentanyl. And they have talked about 90 minutes of surgery is maximum. So they should have mentioned about the intra-opioid administration also. Accepted. Okay, please go to the next slide.
So sample size was calculated as per a previous study. A minimal sample size of 20 in each group was used to achieve a 90% power with a beta of 0.1 and to detect a difference of 1.5 in the median visual analog scale VAS between groups, assuming a common standard deviation of 2.5 using F-test at this level of significance alpha 0.05. Can a numerical value such as visual analog scale have a difference in the median as 1.5?
Yeah, I also have got some observation. Dr. Asha, you can comment on this?
Yeah, so see, there are 2-3 things in this which we could kind of learn from. First is that these are 3 groups they are comparing. So this comparison they have done for just 2 groups, a difference of 1.5. They failed to mention Because if you compare 3 groups, your sample size goes up. Or you apply a Bonferroni correction and then you'd assume, or if you have data for, let's say, group 1 versus 2 and 2 versus 3, then you take the larger of the 2 sizes. That is what ideally should be done. But this is how you will find that we are doing most of the time. And biostatistically, this is not correct. Second thing, we are trying to detect a difference of 1.5 in median VAS. Actually, if you talk to biostatisticians, they have lots of reservations about using VAS. First, they will tell you that this is strictly speaking not a quantitative variable. Quantitative variable by definition means it's from 0 to 100. You put your 0 to infinity, right? Your number can lie anywhere. VAS is defined as 0 to 10. So some people like to call it an ordinal data. So it's ranked. You know, there are certain ranks it belongs to. When you measure VAS, secondly, what relevance, like you were showing in your abstracts that it's a difference of, someone has a VAS of 1.5, someone has a VAS of 1. Does it make a difference in your clinical practice? It doesn't. So there are lots of controversies about VAS, and even when you see the results of this study, we can come back and discuss this in a little more detail. That is all I want
Dr.
to
Asha,
say.
yeah, Dr. Asha, the thing that I don't know too much about this. So when you talk of median, a median is a round number. It cannot be a fraction. So
Correct.
is it okay to say 1.5 difference in the median VAS? I mean,
okay, you are talking about the decimal. You're talking about the 0.5.
Yeah.
So whenever
VAS
we
is
convert,
just one. Yeah.
So no, if we actually, as Dr. Bala also mentioned initially, that there is a difference between NRS and VAS. So VAS means that I ask the patient to put a line somewhere, a hand somewhere, right? What if he puts it between 1 and 2? We customarily think it is going to be only 1 or 2. Similarly, age or weight, let's say I measure it in kgs, but then when I calculate and I apply the statistical analysis, I take it as an average and it is in decimals. So this decimal can be a mathematical derivative of what I'm measuring. That is all right. But VAS itself, using it as a quantitative variable, trying to put this data for 3 groups when there are actually 2, confusing clinical and statistical significance when we talk about VAS. Maybe I should ideally be talking about that if patient has, we say, a VAS of more than 3, we will give analgesic. So let's talk about the percentage of patients who have a VAS more than 3 or less than 3. Let's talk about their rescue analgesic in the post-op. This will make no difference in your clinical practice or to the patient. So
I agree.
That's all.
And this is not a quality statement in terms of the sample size, I think. And in fact, they mentioned the standard deviation of 2.5.
Yes.
I think it is very odd from my knowledge. So when I talk about VAS, yes, 1 to 10 and 1.5, 2 is also odd. 1, 2, 3, 4, 5 it could be.
Yes.
And giving a standard deviation of 2.5 is too much.
Actually, they say, I think they mentioned that rather they have taken it as 3 so that they can include a high. That's also conjectural.
Right.
Either if you are quoting that I'm taking this particular study, then you say that it's 2.5.
Yeah.
Okay.
Okay, please go.
So coming to statistics, these were the tests that were included in the study, but the most commonly used tests were the chi-square test, student t-test, one-way ANOVA test, and the Pearson coefficient.
So coming to the results, the demographics one-way ANOVA tests were used. The age, sex, weight, height, BMI, and the type of surgery were analyzed, and it were comparable in all the 3 groups. It included patients with mean age of 42, 41, and 43. All are female patients. Weight of 80, 79, and 83. Height of 166, 165, and 167. And BMI of 29 in all the 3 groups.
Yeah. So if you look here, they are talking about the different kind of surgery. So this is mentioned because it is a confounding variable. And they have said that the distribution of different is similar across the 3 groups. Right.
Coming to the primary outcome, they checked for the VAS 12 hours post-operatively. They used a one-way ANOVA test, and VAS at 12-hour post-operative was less in high-volume ESPB and standard volume ESPB than the GA-only group, which was 1.75 in high volume and 1.6 in standard volume. But in GA group, it was 3.4 with a p-value of 0.001. But there was no statistically significant difference between the two intervention groups in all the time points.
Can I just make a quick observation here?
Yeah, please.
Look at the standard deviations for these means, because I think this will be a good teaching opportunity. Look at the standard deviations. They are almost 50% of the stated means, 1.7, 0.9, 1.6, 0.8. The moment you look at standard deviations which are larger than 1/4 or 1/5 of the mean, almost always implies that these are not normal in distribution. When they are not normal in distribution, you don't talk about means, you talk about medians. So for the same reason, this graph that they are using, I again have slight objections to it. First, they are using mean of VAS. It should have been median. Secondly, if you are using median, it should have been box plots, because that gives you a median and an interquartile range, IQRs. Third, that means the kind of test which was put to compare the VAS would be different. It cannot be an one-way ANOVA. Fourth, look at the y-axis for your VAS, 0 to 4. The difference between the three groups is being unnecessarily exaggerated. Had I made the 0 to 10, these would have become closer. So this is a sort of a data mining, what you call, that when you get your results, you decide what more can I extract, how can I project it to choose what I want to project. So in essentiality, this VAS finding is highly questionable for a number of reasons. That's how I'd put it. Right?
And one more small observation you just see, because we don't have time. Look at the group, I think group 2. Group 2.
Group 2 is the standard volume group.
Standard group. See, the methodology says at the end of the procedure, two groups were administered another dose of the drug, right?
Yes.
And how is it in? It has gone up at 3 hours in the second group, standard group, right?
Yes, sir.
Okay. Yeah. Even practically, I will not bother much. Also, as Dr. Asha was telling, because it's not 1 to 1.5 or something. Will not be. But there is an exaggerated graphical representation here of a mean VAS, and you look at the diagram. There is actually increase in the score at third hour in the standard group, whereas it has come down even in the control group, where there is no use of the block at all. Okay.
Yes, sir.
Can you see that, right?
Yeah.
Yes,
Yes,
So these are some mistakes which are. It's a very nice selection of article by Madam. So we can critique many points. Next slide, please.
Coming to the injected spread, a chi-square and student T tests were used. The local anesthetic had extended craniocaudally in the high volume group than the standard volume group. In the standard volume group, the craniocaudal spread a mean of 9.15, and in the high volume it is 11.20, with a p-value of 0.027, which is statistically significant. But spread through the paravertebral space is 30% in standard volume, and in high volume it is 40%, and a p of 0.507. And epidural spread is 0 in standard volume group, whereas in high volume group it is 20% spread. In exciting the spinal nerve root, it's 0 in standard volume groups, and in high volume groups it is again 20%. And crossing the midline, in both the groups, two of them, for 2 patients, it has crossed the midline. So there was no difference of.
Yeah, that's what they have commented. So look at the epidural thing. They have said that in the high volume group, 20%, 4, it has crossed in 4 out of 20 patients. And in fact, later on, they have mentioned that it is not significant or may not be significant, but it is a point to be noted. So 20% of the patients with high volume crossing over to the opposite side with the current sample size. So it is still a matter of discussion, and but they have given minimal importance to this particular point. Okay, and that's the reason I said hemodynamic management. I mean, monitoring would also be essential. Maybe with a greater sample size or multiple studies, this could be same or it could become more, and it's a point to be noted. Okay.
Yes. So they did a correlation between the craniocaudal dye spread and VAS in both ESBB groups, and there was no correlation found between these two variables.
So if you have a non-normal data, you cannot apply a correlation test. So again, if VAS is not normally distributed, this entire analysis would be subject to discussion. Go on, please.
Coming to the dermatome level, a student t-test is used, and more dermatomes were covered in the high volume group, 7.20 in the high volume group, than the standard volume group, which is 5.75 dermatomes, with a p-value of 0.014, which is statistically significant. So again, coming to the correlation, a significant strong correlation was found between craniocaudal dye spread and the clinical dermatomal level achieved in both standard volume and the high volume groups.
Why do you say this was significant? Why do you think this is important clinically? P-value? We don't have time, so we'll rush it. So if this p-value was significant, but the R was 0.2, would it still be important? No. It is the R you look at, the correlation. Yes, more than 0.6 to have any kind of meaningful this. And 0.6 means if you square it, that is 6684. So 84% of the variability, 6636. 36% of the variability will be explained by this particular factor. Rest is all dependent on some other variables. That's what this means. Okay. Next, please.
Coming to sedation, at arrival to the PSU, most of the cases in the standard volume and high volume ESPB groups were slightly sedated, with a median RAS of -1 in both groups, while in GA group, most of the cases were agitated, with a median RAS of 1 and a p-value of 0.002. But 4 hours later, the ESPB groups were awake and calm, and the GA groups were still agitated. But from 8 hours onwards till the end of observation, most of the cases overall in all the groups were awake and calm.
This graph shows negative RAS scale. Do you see that?
Yes.
It is not negative.
-1.
Yes, it can never be. So I don't know what's being depicted. Next.
If the RAS is -1, would it not show negative? The RAS minus means more calm. They are only responsive to an intervention like call.
It is part of the assessment.
So it's part of the assessment. It's ordinal scales. So if they are saying median, then again, it should have been a box plot and the IQR should have been visible on this too.
Okay.
So I mean, putting dots for median doesn't kind of work.
Right. Next slide.
Coming to satisfaction, both ESPB groups showed a slight statistically higher levels of satisfaction than the GA only group, with a p-value of 0.001. And again, coming to correlation, there was no correlation between the craniocaudal dye spread and the satisfaction in both ESPB groups.
Coming to discussion regarding the dosage of the drug, Altiparmak and his colleagues had used a fixed volume of a 20 ml, but with variable concentrations of 0.375 and 0.25%, yielding 75 mg and 50 mg of bupivacaine in each group. So they found that high dose group had more decrease in the NRS, numeric rating scale. But in the current study, it was the same dose of 50 mg of bupivacaine was used. Hence, analgesic effectiveness of the ESPB is related to the total LA dosage. Tyagi et al. And Govender et al. Had offered a dosage of 0.5 ml per kg and 0.1 ml per kg per dermatome in pediatric patients. But these latest study findings cannot be generalized because it was done in the pediatric patients and in the cadaveric patients. So in the current study, the relationship between the volume injected and the spread is not linear, as doubling the volume from 20 to 40 ml had resulted in 22% increase in the craniocaudal spread, that is from 9.15 to 11.2 vertebral levels. Paravertebral spread to the paravertebral space has been demonstrated in 8 cadaveric studies, and the current study confirmed the spread to the paravertebral space in 30% of the cases in the standard volume ESPP group and 40% of the cases in the high volume ESPP group. This 10% difference between these two groups is statistically insignificant, so the spread to the paravertebral space may depend on other factors besides the volume of the drug injected. Choi et al. Had revealed a marked difference between 10 ml and 30 ml volumes regarding the spread to the paravertebral space. 30 ml is better than the 10 ml, but not 20 ml used in their previous study. The degree of injected spread to the back muscles and the facial layers seem to be largely enhanced when the injected volume for the ESPP is increased, comparing to the extent of the paravertebral spread. ESPP may cause injected spread to a larger area of the thoracic back region as a function of injection volume. Degree of paravertebral spread may not be considerably increased by increasing injection volume beyond 20 ml at a single level. Epidural spread, the degree of the injected spread to the back muscles and the facial layers related to the volume administered. The current study showed spread to the epidural space in 20% of the cases in the high volume ESPP group, whereas there were no epidural spread in the standard volume group. The result of the other studies were variable, and epidural study had been confirmed in 4 cadaveric studies and contraindicated in other 4 studies. Different tissue tensions, muscle tone, body temperature, solution density, and variations in the intra-abdominal pressure generated by the breathing are all anatomical factors that may affect the spread. So the local anesthetic volume injected in this block is not the sole factor affecting the spread to the epidural space. Time to assessment of the dermatomes. Barrios et al. Has evaluated the sensory block 60 minutes after completion of the ASPB by a change in feeling to both pinprick and cold methods. And the mean volume of the drug required per dermatome in ESPB was 2.2 ml, ranging from 1.81 to 2.5 ml, according to Barrios et al. But in the current study, the sensory block has been assessed with the presence of an hyposthesia along the mid-clavicular line 15 minutes after the block using iced water soaked piece of cotton, and the standard volume group had 3.4 ml of local anesthetic per dermatome and 5.5 ml per dermatome was required in the high volume group. Therefore, time is an important factor in the gradual spread of local anesthetic. Mechanism of action. Among the analgesic mechanisms of ESPP are local anesthetic spread to the paravertebral and the epidural spaces. So systemic absorption of the local anesthetic can increase its plasma concentration, and local anesthetic immunomodulation and local anesthetic effect on the thoracolumbar fascia. Clinical physiological, cadaveric, veterinary, and biomechanical laboratory research all point to a direct action of the LA on neuronal structures in the fascia, deep to the erector spinae muscle and nearby tissues as the most probable fundamental mechanism. Effectiveness of the block. ESPP is non-inferior to the paravertebral block in terms of controlling post-mastectomy pain. Paravertebral block provides analgesia to all the 4 quadrants of the breast, but not to the infraclavicular region, which required pectoral nervous 2 block, which provides analgesia to the upper outer quadrant. Serratus plane block provides analgesia to the lower outer quadrant, and parasternal block and transverse thoracic muscle plane block provides analgesia to the inner quadrants. So combining all these facial plane blocks is recommended for complete intraoperative and postoperative analgesia for oncological breast surgeries. In agreement with the current study, Unal et al. Reported a high frequency of agitation in the control group compared to the ESPP group. Also, Shim et al. Provide the ESPP successfully attenuated the degree of postoperative emergence agitation. So, Richard sedation agitation scale was used in both the above studies. On the converse, Elsa-Beni et al. Used Ramsay sedation score and reported higher level of sedation in the control group than ESPP group. The scales used for assessment may explain the difference in these results, and the scales are nearly similar in terms of inter-rater reliability, yet they are different in the design and construct validity. Also, ESPP can decrease agitation due to better analgesia and can also decrease sedation due to less needs for opioids.
So coming to the limitations of the study, in the control group, preemptive analgesia was not adequate, and this may explain many patients in this group were agitated for 8 postoperative hours. And also the interval between the blockade and CT scanning is 15 minutes. That may be too short to allow adequate and optimum LA spread. And the term standard volume ESP may be misguiding, as there is no standard volume set for ESPB so far. So on concluding, preoperative ESPB is an excellent analgesic modality for breast cancer surgery, and it can attenuate both postoperative agitation and sedation. Doubling the injected volume enhances the craniocaudal spreading, and it may be useful for surgeries requiring multiple dermatomes. However, larger volume has no effect on analgesic efficacy or patient satisfaction, as there is no further spread to the paravertebral epidural space or the spinal nerve wrapping.
Last slide.
References also.
Okay. Actually, go back to just the previous slide, that conclusion thing, the last part. So, you are happy with their statement on 40 ml PGs? So, I am not talking about all the statistics and the deeper aspects of methodology. Some of them would be difficult for you. But overall, at the end of this presentation now, they have used 40 ml, 20 ml, and a patient group where nothing has been used as a block. So is it okay to talk about that 40 ml straight away? Why the authors did not try 30 ml? Did it strike you? Because one of the references they have put is about 30 ml.
30 ml. But they have used concentration of like 0.25 and 0.125, sir.
Yeah, that is true. So
when you dilute it, you get it 40 ml.
No, they could have got an intermediate volume also, right? So based upon the number of dermatomes, because they have given per dermatomal distribution also, they have cited some articles.
Yes.
So in research, basically, again, safety is very important. So when something has been proven to be very effective in 20 ml volume, so trying to see that whether there is further advantage, they could have gone to 30 ml. So if I was to criticize, analyze, I will probably think of 30 ml before going to 40 ml. It could be a comparison of 20 and 30. That's one thing I thought. Secondly, one study you failed to refer. There is some Ajvado study which it's there in the text, right? So where those authors have spoken about the possible anterior spread of the drug that is deposited in the Erector spinae. Okay. So these authors have used CT. Having used CT, it was very easy it would have been very easy for them to even check and try to find out whether there was any anterior spread. At least they could have mentioned the methodology, not just the spread craniocaudal and paravertebral and epidural and the spinal outlet and other things. They could have also mentioned about a possible anterior spread. Even though there may not have been any, and because he has cited an article in the discussion part by Ajvada et al., where they have spoken about risk of the anterior spread. So when there is a risk of anterior spread, there is a risk of muscle weakness. And when you talk about muscle weakness, the secondary muscles, the intercostals and all, there is some risk, and of course the back muscles. So this is some.
I think, sir, their CT was probably done later. This was done very soon.
Okay.
And maybe there wasn't enough time to, to have that anterior spread. I feel trying to do a CT at 15 minutes may have had its limitations in this study.
Yeah, they could have acknowledged. That's why I said, no, there will be practical problems. The authors could have mentioned this particular aspect also. They did talk about 15 minutes being inadequate to totally assess a spread.
Yes.
They could have also just commented that there is also evidence that somebody has done this and we didn't have time to do this. And this is a possible limitation. That's just my observation.
Yes.
And overall, this article has got too much of discussion. Normally, that much of discussion is not allowed in publications. Too many details have been given, but they could have made it more composed, small also.
And just one more thing, they talk about giving morphine post-operatively, and but it is not mentioned anywhere in the results. That would have been a wonderful indicator for the efficacy with GA. There's just no mention of it, despite saying it in the methodology that they're going to use a PCA.
Yes, ma'am.
Yeah, I think so. They have actually talked about even use of the additional drugs.
Yes, but there is no mention of them in the results section to prove that, yes, this was actually done.
That is true. That is true. Yeah. So I think largely much of the topic has been covered for the postgraduate level at this point of time.
And I think all four of them did a wonderful job presenting it for the first time and braving this. So it was very nice.
What would be the Likert scale of satisfaction for two groups? Ludhiana group and Amrita group.
10 out of 10.
10 out of 10. Is there a 10 of Likert scale? Again, a question to them.
No, it can be as much. I'd like to.
For them.
Yes. Yes.
So Dr. Sanish, I think.
Thank you very much, sir. Thank you very much to all three moderators for giving us a wonderful session, and both the teams also. Postgraduates, I think they had performed wonderfully well. You can always text us by email, icawebinars@gmail.com. I would like to invite Dr. Baljit Singh, our CEO of Indian College of Anesthesiologists, to give away the E-Certificate of Appreciation to our young colleagues, the postgraduates from DMCH Ludhiana and Amrita Institute of Medical Sciences.
Thank you so much, Dr. Sanish. After a very wonderful program today, it was a unique program, one of its kind, first one, where the cases were presented by the students. And there were three masters who threadbare analyzed the whole, the paper, the whole manuscript, as to where there was a lacuna and what could have been done. I think this is a great learning for the students, and learning from such Bhaskar, the past president, ISC National, and Dr. Asha Tyagi from UCMS Delhi, and of course Dr. Lekshmi Kumar from Amrita Institute Kochi. Three experts did a wonderful job, and my heartfelt compliments to all three of them for handling, and not just handling, it is basically analyzing so threadbare that one could make out that there are so many lacunae. Normally, under patient, still you can. And an expert looking at the paper, there are a lot of things that can still be made out. Probably the journal reviewers perhaps have missed out. Anyway, next to the experts, and of course to the postgraduate students who, as Dr. Asha Tyagi said,
and these are our E-Certificate of Appreciation from Indian College of Anesthesiologists for our postgraduate presenters. Ma'am, shall I read out the certificates?
Yes, of course.
Okay. Dr. Roshal Naya, Dayanand Medical College, Ludhiana. Congratulations. Keep it up.
Thank you, sir.
Dr. Sunanda Sethi, again, Dayanand Medical College, Ludhiana. Our appreciation from Indian College of Anesthesiologists.
Thank you so much, sir. Thank you.
Dr. Krutika Sri Manoharan from Amrita Institute of Medical Sciences, Kochi. And Dr. Varshini Ravindran from Amrita Institute of Medical Sciences, Kochi. So these are our young voices that we presented in our ICA webinar platform as part of ICA PG Assemblies. Now it's over to Dr. Jayashree Sood for the concluding remarks and vote of thanks.
It's my pleasant duty to thank our moderators, Dr. Bala, Bhaskar, Dr. Lakshmi, and Dr. Asha Tyagi for this wonderful moderation on this very important topic. And especially this journal club could not have been better moderated. And it was so important for the students to understand and to learn, because many of the institutions do not have such regular programs and journal clubs in their departments. But thank you so much, all of you. And a special thanks to our students, Dr. Rushal, Dr. Sunanda, and Dr. I have the names.
And Dr. Varshini.
Dr. Kritika and Dr. Varshini. Heartiest congratulations and all the best. You did a wonderful job, and we are hoping that we'll see you on this platform in the future. And all the best. Thank you very much. Thank you so much. Thank you, and see you all. Hoping to see many of you in Chandigarh on the 4th. Thank you and good night.